Hello everyone, welcome to your lecture on the principles of pharmacology. These are the objectives we will be covering in this lecture. What is pharmacology? Pharmacology is the study of drugs. It's the scientific study of drugs, their sources, where they come from, chemistry, how they are made up, how they act, and what they are used for. A drug is any chemical that affects the body. Right? It can be prescriptions, over the counter, we call OTC, herbs, vitamins, minerals, foods. This is why the regulation agency is called the Food and Drug Administration, because both foods and drugs are a drug. Now, naming a drug, it's called drug nomenclature, right? Drug has a generic name, which is the official name of the drug. It doesn't belong to anyone. Nobody can claim a right over it and say this is only our drug. It's the official name of the drug. It's non-proprietary. Then we have the trade name, which is the brand name of the drug. Now this is a registered trademark. You'll see the little R inside a circle. It's owned by the manufacturer and they have exclusive right to produce that drug with that name for 20 years after it's registered. Then we have the chemical name. So this is the chemical makeup of the drug. And it's established by the IUPAC. And these are some examples of the generic trade and chemical names. So let's look at the first one. We have epinephrine hydrochloride USP. That's the generic name. Okay, so nobody owns it. It's the official name. Then we have the trade name, which is adrenaline or EpiPen. I'm sure a lot of you have heard of EpiPens. That's the one we take when when we have an allergic reaction. But EpiPen is a trade name, a brand name. Then we have the chemical name, which is this really long name. It's just the chemical structure of that medication. Another example is aspirin, is the generic official name. Then we have Bayer aspirin, which is Bayer is the trade name. And aspirin has a lot of trade names, a lot of different companies, sell aspirin. Then we have the chemical name, acetylsalicylic acid. And there's another example with ibuprofen over there. So what is pharmacology? I mean, we know what a drug is now. It can be a drug or food. We know it's regulated by the FDA, and then we know that it has a generic chemical name and a brand name. And what is pharmacology, right? Pharmacology is the cycle of drugs. First of all, it's the study of drugs and how it affects the body. Drug is also known as a medication. So there's a cycle of drugs, we call. The physician orders the drug, the pharmacist will prepare it and dispense it, and the nurse will administer it. So this cycle helps us to keep our checks and balances. For example, if the physician makes a mistake with the order of the drug, the pharmacist has the opportunity to catch that error and fix it. And if the pharmacist makes that mistake, there's an error over there in the dispensing of the drug, then the nurse has that opportunity to correct that error. Right? And that's the reason why it's so important to follow our checks and rights of medication administration. So the principles of pharmacology are comprised of naming of the drug nomenclature, the types of drug preparations, the different ways the drug is prepared, the classification of a drug, the indication of a drug, why is it being given, mechanism of drug action, basically mechanism of action, which means how is the drug working in the body. Adverse drug reactions. What reactions can the drug cause? What side effects do we expect from this drug, right? What factors affect, how the drug acts on your body, right? Then some drugs need monitoring, so we do, lab tests to monitor drug levels. Let's talk about one drug nomenclature. We just talked a little bit about that earlier. You have your generic name, your chemical name, and your trade name. Please read over this slide. Then we have classification. The drug is classified by structure, which is the pharmaceutical class, or the therapeutic use, which is the therapeutic class. So for example, beta adrenergic blockers are the pharmaceutical class. right? Then under the pharmaceutical class, we have how does the drug work, mechanism of action, physiologic effect, and then chemical structure of the drug. All of these fall under the pharmaceutical class. Then we have the therapeutic use of the drug, right? This is why is the drug being given? What's the clinical indication for it? And how does it act on the body? What do you expect will happen when the patient receives this medication? So these are two different classifications which are important for you to know as well. Let's look at prescriptions. Prescriptions versus non-prescription drugs, right? The prescription medication needs an order. You have to have an order to get it, right? I can't go to the pharmacy and say, hey, I want, I don't know, morphine. You know, they're not just going to give it to me. You need an order from a doctor to get certain drugs. So each of those prescription drugs, they're called legend drugs because they have this label by law on the medication itself. Then we have non-prescription drugs. These are all the over-the-counter drugs that you see on the shelves in the pharmacy. You do not need an order for it. Say, for example, if you have a headache, you can go to the drugstore and buy acetaminophen, Tylenol, or ibuprofen, one of those medications over the counter. You do not need a drug order for it. Now, drugs are legislated, by different regulating agencies. We have the Food and Drug Administration, then we have the Drug Enforcement Administration. So these are the regulating agencies that regulate different types of drugs, right? So this is over here gives you a timeline of how legislation, affected drugs in the United States. For example, in 1906, we had the Pure Food and Drug Act. It wasn't until 1970 where there was actually a Controlled Substance Act, which regulated the distribution of narcotics and other drugs of abuse, right? They were categorized based on the therapeutic usefulness and potential for use and abuse, which was causing substance use disorder or substance addiction. So now they have different schedules for it. In 1983, the DEA was identified as the nation's sole legal drug enforcement, agency. Then in 1997, we had the Food and Drug Administration Modernization Act. So these are all the different, legislations, on drugs over the past since 1906. Scheduled substances. In 1970, we mentioned that the Drug Controlled Substance Act came out. So this was done to categorize drugs based on their usefulness and potential for abuse, right? So if there's a high potential for abuse, then they try to figure out, okay, how useful is this drug? Do we really need to have this drug? Right? And so because it was causing substance use disorder and addiction in people. And so now we have different schedules for these drugs. Schedule 1 is heroin. High potential, extremely high potential for dependency. It has absolutely no therapeutic use. So we do not get prescriptions. It cannot even be prescribed in the United States. No doctor prescribes heroin or LSD for any patient because it has no therapeutic use. Then we have Schedule 2. This has a high potential for dependency, very likely that people can get addicted to it. But the reason why it is prescribed is because there are therapeutic uses for it. That means that it's helping with something for that patient. When, for example, when the patient really needs pain relief, it helps them with the pain relief. Right? But there are a lot of restrictions on these Schedule 2 substances. The prescription needs to be on a tamper-resistant prescription pad on a paper with the prescriber's DEA number. The prescriber can't fax it or email it to the pharmacy or call it in. The patient has to take an actual prescription on that sheet and take it to the pharmacy. And they could only order 30-day supplies at a time. And they cannot give you refills for it. They can't say, okay, I'm going to give you 30 days of, morphine for the next 2 years. No, it's only a 30-day supply at a time. These are morphine, codeine, Demerol. Then these are used for analgesics. Then you have stimulants such as cocaine and Adderall. Then you have sedatives like phenobarbital, or Barbitol and, Seconal. Then we have Schedule 3. These have a little less potential for abuse. They still require the tamper-resistant prescription paper. You can have refills, and it can be phoned or faxed into the pharmacy. So these are combination drugs. For example, a narcotic plus a non-narcotic. For example, Tylenol plus codeine, Vicodin. So they have less potential for abuse. Then we have Schedule 4, which is a regular prescription. The DAA number is still required, and it's called, for example, examples of these are Valium-like drugs. For example, you have Xanax, you have Ambien, medications like that. Then we have Schedule 5, which is a little potential for abuse. There's no refill limitations. You can give as many refills as you want. Examples are Robitussin. Even Lomotil is a, prescription dose. Some people actually use Lomotil to feel good. I mean, that's really desperate, but, they do. Okay. So why does it even matter to the nurse? Like, what does the nurse care about? What do we need to know? What do we care about as nurses when it comes to our patients and administering medications? The pharmacotherapeutics. That is what nurses are, interested in. They want to know, what effect will this have on my patient? And so use of drugs to prevent, or treat disease, drug therapy. Did it work? Did it have a therapeutic effect? Did it not work? Did it actually have an adverse effects? So we want to know the indication. If the doctor orders a medication, I want to know, okay, why is my patient getting this medication? And it's very important for us as nurses to understand that, because that's the only way we can catch an error. The nursing responsibility for pharmacotherapeutics. Understand what the outcome is of that medication. Assess whether the drug is appropriate, to administer to the patient. Yes, as nurses, we can do that. That's our check and balances, right? And if we don't understand why, we can always ask the physician, hey, I noticed that this patient has this drug. I just wanted to verify why my patient is getting this drug. Okay? Provide appropriate, accurate education to our patients. Give them the information about the drug. Let them make an informed decision on whether or not they want that drug in their body, because that is their body and they have the right to refuse a medication. Then under pharmacotherapeutics, what is that? It's a dynamic that achieves the desired therapeutic effect of the drug without other undesirable effects. Basically, I want the drug to work without having the patient having complications. Now, there are different ways of doing this. You can monitor their serum levels, their blood levels. Sometimes for some medications, they monitor the blood levels before the start, during the therapy, and after, right? And maintaining that therapeutic range. What is the therapeutic range? It's the concentration of the drug in the blood that produces the desired effect without causing toxicity. That's a therapeutic range. Basically saying that there's enough of that medicated drug in your blood where it's causing the desired effect, it's working, but it's not causing toxicity. We want that balance, that, very delicate balance there. Doing an accurate medication reconciliation is so important for nurses. This is a process of creating an accurate list of all the medication the patient is taking, with the goal of providing correct medications to the patient at all transition points, basically through their transition of care. For example, if a patient comes to the hospital, they were already taking medications in their home. The nurse needs to know, what were you taking at home? Now the doctor orders a bunch of new drugs or takes away some drugs and orders drug ABC during the hospital stay. Then they're taking that. Now they go to, for example, a skilled nursing facility. What is the skilled nursing facility going to give them? So you see how the medications are changing. And so at each point, it is extremely important for the nurse to look at what medications they were taking. Are they getting all the right medications? Are they getting unnecessary medications? And that can be done through medication reconciliation. Check for contraindications. If the patient has a disease that makes the use of that drug dangerous for that patient, for example, if there is a drug that is metabolized through the liver and the patient has liver disease, then question that drug. And then you want to create patient-centered treatment plans that include several types and combinations of therapies. So how does the drug work in the body? These are the phases of drug activity. Pharmaceutical phase is the why phase. We just talked about it. Why does the patient need that drug? That's when you're actually administering the drug to that patient. So what are the different components of that? It's the disintegration of the dosage form. How, if I'm giving the patient a pill, how is that pill going to, be taken by the patient, right? Am I going to crush it and, administer it through their tube? Am I going to give it to their mouth? Am I giving an injection that's going to go through their muscle or their subcutaneous tissue? So this is the pharmaceutical phase. It's the disintegration of the drug form, the dissolution of the drug in the body, your administration. That's when you're giving the drug to the patient. Then you have the pharmacokinetic phase, right? How is that drug going to work? So pharmacokinetic phase is what the body does to the drug. There's a difference between the pharmacokinetic and pharmacodynamic phase. Pharmacokinetics is what your body is doing to that drug. So now the patient has swallowed that pill. Now, what is the patient's body going to do to that drug, right? So it has different phases. It has absorption, distribution, metabolism, and excretion. And we're going to talk a little bit about that, in the next few slides. Then we have the pharmacodynamic phase. Now the drug is available in the body. Now, what is the drug going to do to the body? Right? So first we took the medication. We administered the medication, The second phase is what the body does to that drug once it gets in. And then the third phase is what will that drug do to your body? So now if the patient was in pain and you administered a pain medication, what do we want that drug to do to the body? We want that drug to reduce that pain or take away that pain, right? And that is highly dependent on the drug receptor interaction, which we'll talk about in a few slides from now. So the pharmaceutical phase. This is the phase where we're actually administering the drug. Okay, the doctor ordered the medication, the pharmacy dispensed it, and now we're about to administer the drug. So this includes, the different forms of medications. We have different types, different preparations. So this is, for example, we have oral drugs in a solid or liquid form. We have enteric-coated drugs, which have a coating that prevent the breakdown from the acid in the stomach. So we don't want the drug to break down in the stomach from the acid in there. So they're enteric-coated so they can actually reach the intestines where they can be absorbed. Then we have extended release medication. Extended release drugs are drugs that break up over a period of time. They don't break down right away. So the drug molecules stay in your GI tract over a long period of time. These should never be crushed. Enteric-coated or extended release. Always remember, they're never crushed because they're not going to work the way they should if you crush them. Then we have immediate release drugs, right? They get released immediately as soon as they go into your stomach. So the different dosage forms are enteral, anything that is processed through your GI tract; parenteral, anything that's injected into you or put straight into your venous system through your blood; and then we have topical that we put over the skin, for example, or we inhale. These are all topical. So which ones work the fastest? Over there on top, you'll see there's a little list over there that shows you which ones work the fastest. The slowest ones are the enteric-coated ones, then the coated tablets, then tablets and capsules, and then powders and suspensions. And then the fastest are, buccal tablets, or the ones that are, sublingual. And the fastest medication will be the ones that you directly inject through the venous system. These are the different types of drug preparations. Again, it's a whole list of them. Please read over these. It's extremely important for you to know each of these and how they're administered. Now let's move on to the pharmacokinetic phase. This is the second phase. Remember, we talked about the drug administration part where you administer the medication. You need to know what kind of medications are available, what forms they're available in. For example, tablets, enteric-coated, immediate release, extended release, injections, how, all the different types. Now we're going to go to the pharmacokinetic phase. This is the phase when, as I mentioned, which tells us what the body does to the drug. Okay, so now you administered the tablet to your patient. Now what is the patient's body going to do to that drug? The first stage of it is absorption. This is the stage where the movement of the drug from its site of administration into the bloodstream to get distributed to the tissues in your body. For example, if you swallowed the pill, now it's going to go inside and it's going to get absorbed and distributed to the tissues in your body. And now the drug is available. So the bioavailability is the extent of drug absorption. If the more the drug is available, the higher the bioavailability, right? The more of it that's absorbed, the higher the bioavailability. Now, one thing you have to remember is that the cell membranes in your body are fatty in nature. So for example, for the drugs to be absorbed across these cell membranes, to get past these fatty cell membranes, they have to be fat soluble, right? So that way they penetrate through the cell membranes and get to the parts of the body that need that drug. But if the pills or the drug is water soluble, they cannot get across those cell membranes. So there are different factors that affect how fast a drug is absorbed in the body. First of all is the route of administration. How are we taking it? Remember, we in the earlier slide right here, this over here shows you which drugs work faster and which drugs work slower. Now going back to absorption, that's one of the factors that affects how much of the drug or how fast the drug gets absorbed. Right? So the oral route goes from the stomach to the intestine to the liver. The liver breaks it down into metabolites, and then it gets, distributed in the body. So it's a longer route. But if you inject the medication straight into the venous system, then, it starts working right away because it passes all of those stages and goes straight to the blood. So that's the reason why, IV medications work faster than oral medications. Or for example, a sublingual tablet works faster than an oral medication because it's absorbed, differently and it's available, faster. Another thing that affects how, the drug gets absorbed in your body is the dosage of the drug. The higher the dosage, the higher the concentration, which means the higher rate of absorption. So if I take a Tylenol that's, say, 375 milligrams or 350 milligrams compared to Tylenol of 1,000 milligrams, the higher the dose I'm taking, the higher the concentration that will get to my body, and the higher rate of absorption that in my body. So that also affects the absorption. Then we have lipid solubility. Like we mentioned earlier, the cell membranes are fatty in nature, and so drugs that are fat soluble will get absorbed across the membranes and work better. Drugs that are water soluble cannot be absorbed by the cell membranes. It cannot penetrate the cell membranes and get absorbed, faster. Now, absorption. This is basically the movement of the drug from the site of administration to the bloodstream. And please read over this. These are some definition of the different terms that you will see related to absorption. Then let's talk about distribution. What is distribution? Distribution is the movement of the drug through the body. So now the drug was administered. It gets absorbed. The patient swallows the medication, goes through the GI tract, gets to the liver, gets transformed into metabolites to get absorbed, and now it needs to be distributed to the tissues in the body. This is the distribution phase. So the big thing that works over here are the receptor sites in our body. We have active sites that create reaction. We have acceptor sites, which are inactive. The drug will connect to them, but they will not create a reaction, right? And then sometimes the drug gets accumulated, and redistributed to a different area of the body. So this is basically the movement of the drug by the circulatory system to the site of action. That's distribution. What are the factors that affect it? Is adequacy of blood circulation. So yes, the drug gets into your blood. Now it needs to be circulated. But if you have circulation issues, if you have vascular problems, or, then it's going to affect the way that drug gets distributed to your body. Right? Protein binding, which affects the drug's ability to leave the bloodstream or storage areas, right? So that also affects how the drug is distributed. Then you also have different areas where, you have these permeable blood-brain barrier. Actually, for example, we have one that we call the blood-brain barrier, which protects the central nervous system. So some drugs cannot penetrate through that to get to the site. Then we have metabolism. Once the drug is absorbed and distributed, now we have metabolism, right? What is metabolism? Metabolism is the biotransformation of the drug, right? So once it's distributed to the tissue, now what is the tissue going to do to it? What is the drug going to do at that tissue level, right? It's going to transform. And that's what we call biotransformation. So the liver transforms that drug into an inactive form, a lipid-soluble to a water-soluble, so it cannot move across the cell membranes. This substance that the liver transforms it to is called a metabolite. Because remember, any foreign object that you put into your body, even food, right? What happens when we eat food? The food gets digested and we, have a bowel movement. So your body is going to try to get rid of anything that goes inside it. And so the same thing happens with medications. Yes, you take the medication. For example, you have a headache, you take acetaminophen or ibuprofen, but what is your body trying to do? Your body is trying to get rid of that drug out of your body. It's trying to excrete it. It wants it out. It doesn't want it in there, right? And so that's the reason why you have the different forms of drugs. So to delay that excretion, so it will actually work in the body, right? The body doesn't recognize this as, okay, this is a medication. You have a headache? Okay, sure, here, take this Tylenol. No, your body looks at it as a foreign object and is trying to get rid of it. And so what happens in metabolism is that the liver transforms this drug into an inactive form. If the drug is a lipid-soluble drug, it's going to change it to a water-soluble form, which is called a metabolite, so it can get rid of it. Because if it's lipid-soluble, it's going to penetrate those membranes and get to different parts of your body. But your body doesn't want that to happen. So what factors affect how fast a drug gets metabolized in your body? How well the drug, your liver metabolizes that drug, right? It's your age, the age of the patient, how old or young. For example, if you have an older adult who has liver disease or kidney disease, or other, chronic illnesses, then the drug will, metabolize differently than a younger person, an average, younger person who's, healthier. If a person has liver disease, cirrhosis, hepatitis, then the metabolism will get affected. In that case, physicians usually prescribe lower doses. Then we have drug tolerance. For example, when taking a drug over and over, the liver produces more and more enzymes that break it down faster. For example, take coffee. Remember, we said food is also, a drug. Coffee is a drug. We drink coffee, right? Every day, say for example, we drink a medium-sized coffee. After a while, then that medium doesn't work anymore. We're like, okay, I need more coffee. I need more coffee. And then you start buying the larger size, the venti size. And then So what's happening is that coffee is going in your body, your liver breaks it down into metabolites and gets rid of it. And then it gets really good at metabolizing it because you're always, taking it. And so it keeps metabolizing, it gets better and better and better and more efficient at excreting it. And so now what happens, you need higher levels of the coffee or more coffee to maintain that same effect. So now if you took a break from drinking that coffee, say for example, if you didn't drink coffee for a week, and a week later you buy a coffee and you drink it and boom, it just takes that effect because now your liver has to build that efficiency again. This is called drug tolerance. So the more you take something, the more tolerant you're going to become to it and the more you're going to need it. This is not the same as addiction though. Drug addiction is different and we're going to talk about that, a little bit more. So the life of a drug, right? Also, what is the life of a drug? We have the therapeutic level. That's the level we want it at. We want it to that amount we mentioned earlier. Therapeutic level, the range is the amount of the drug, concentration of the drug in the body without causing toxicity. That's the level we want it at. Then we have the peak level, right? This is where the drug is the most efficient. So drugs have peak levels. You take, for example, acetaminophen or ibuprofen, after a certain time, it could be an hour or so. It's a peak level. That's when the patient is going to feel that effect the most. That's the most pain relief they're going to get right there, is the peak level. Half-life is the point when the drug level drops to half of that concentration in the bloodstream. And then we have the trough level, is the lowest level of drug in the body. Now, with the half-life, every drug is different. Every drug's half-life is different. For example, penicillins have a 1 hour half-life. That means in 1 hour, the amount of drug concentration in your body, in the blood, is half of the total. Then we have acetaminophen, which is 3 hours. You take a 500 milligram acetaminophen or Tylenol. 3 hours later, only half of it is in your body, right? Morphine, 4 hours. Digoxin is 4 days. It takes 4 days for your body to excrete half of that digoxin from the blood. Right? And so that's pretty long. That's the reason why you have to be very careful when you're giving digoxin because it can cause toxicity, right? The trough level is the lowest level of the drug in your body. This over here is a diagram that shows the half-life, the peak level, the trough level. Toxicity is where, there's so much drug in your body that it causes toxicity. Then therapeutic range is the range that we want it at. So these are different, again, another slide on metabolism. Please read over this. There are some important definitions over there. Then finally, we have excretion. This is the removal of the drug from the body. So how does the drug get removed from the body? Remember, we said that anything that you put in your body, food or drugs, your body is trying to excrete it. That's the job of the body, looks at it as a foreign object and it wants to excrete it. So what are the different components of excretion? We have the kidneys, first of all, right? You have the GFR, the I can never pronounce that word properly, filtration, where all of the metabolites, remember the liver metabolized it, turned it into metabolites, which are the water-soluble form of that drug, and then it's excreted in the urine. And so you have how well your kidney is filtering these metabolites out of your body into the urine, right? And then these are the factors. The kidney has a huge effect on the excretion, how it gets excreted. Then we have biliary secretion. So remember, once again, the drug is considered a foreign object and the body is getting rid of it. It tries to excrete it. So either it will excrete it through the kidneys in the form of urine, right? Because remember, your kidneys are producing urine. And so the metabolites go into the urine and they excrete it out in the urine. You can also have biliary secretion, right? This is another way your body tries to get rid of that drug. and get it excreted out of your body. Some drugs that are excreted through the bile duct into the intestines. So it goes into your intestine and then it comes out with your feces, right? For example, it causes GI discomfort, nausea, vomiting, diarrhea. So when drugs are excreted through the biliary secretion into your intestines, it can cause this. That's the reason why it's so important to check liver function when you are giving acetaminophen. Then we have the lungs. Some drugs, they're eliminated from your body, excreted from your body through the lungs when you exhale, right? For example, alcohol. That's the reason why when people get stopped for DUI, and police stops them, they do a breathalyzer test, because alcohol gets excreted through your lungs as you're exhaling. Then we have sweat and saliva. Some drugs get excreted, small amounts of the drug, though, they're excreted through your saliva or your sweat. For example, tetracyclines is an antibiotic that tends to get excreted through your saliva. And that's the reason why it's contraindicated in some people, because it can cause tooth decay, because if it's coming out of your saliva, you have amounts of that drug on your teeth, which cause tooth decay. Some drugs are excreted through mother's milk. Again, one of them is tetracycline, because it binds to calcium ions. And as the mother is breastfeeding, the breast milk has calcium. It's now the tetracycline is bond to the calcium, and it goes into, it gets excreted through the mother's milk. And that's the reason why some drugs are contraindicated for breastfeeding mothers, because we don't want that medication excreting through the breast milk and going to the infant. Right? Now, what affects excretion? Now we know that drugs get absorbed, then they get distributed into the body, they get metabolized by the the liver into metabolites, and now your body is excreting them through your kidneys, biliary secretion, lungs, sweat, saliva, and mother's milk. What affects excretion? How well that the drug gets excreted through your body is affected by, again, aging. If you have any disease, for example, if your, kidneys aren't working. Well, if you have kidney disease, then the excretion of the kidneys, via the urine, excretion of the drug, via the urine, it's going to get affected. So what's going to happen if the kidneys cannot excrete that drug? The drug stays in your body, right? It lingers there and causes toxicity. So that's the reason why it's very important to check to see what, how old your patient is, if they have any kidney disease, if they have any liver disease. All of these are extremely important for nurses to keep an eye on. This is a PowerPoint with some definitions of excretion here. Please read over it. So this here is in a nutshell, everything we talked about on pharmacokinetics. You have absorption, you have distribution, you have metabolism, excretion. This is a summary of all of that. This diagram over here also is a picture showing how the drug gets absorbed. For example, administration and absorption of the drug, right? Whether it's IV, it's oral, subcutaneous, whether it's transdermal, whether you're inhaling it. Then the distribution of it, and then the metabolism of it, and then the excretion of it right here. So the third phase and the final phase is pharmacodynamic phase. So this is what the drug does to the body. We talked about what the body does to the drug in the pharmacokinetic phase. Now let's talk about pharmacodynamic phase. In the pharmacodynamic phase, sorry, I don't know what happened here. Sorry, there you go. So how does the drug work? The time course of the drug. We have the onset of action, when the drug actually starts to work. That's called the minimal effective concentration. This is affected by how the drug is taken. Oral is the slowest, remember, and the drug dose. Higher the concentration, the higher therapeutic effect. How long does the drug affect the body? This is affected by the dose of the drug, the rate of distribution, metabolism, and excretion. Remember, your body's trying to get rid of it, but if the drug is formed in a way where that gets delayed, then it will take, better effect. For example, when we take a Tylenol for a headache, what's the peak level? Go ahead and look in your drug guide and see what's the peak level for Tylenol. Mechanism of action. Remember, drugs affect the physiological processes within the cell. They don't produce new actions within the body. This is a very important concept for us to understand, that a drug does not add anything to your body. What it does, it produces an effect with something that's already inside you. That's what drugs do. So now we have different receptor sites. We have agonists, antagonists, and agonists and antagonists. So these are the receptor sites that the drug connects to when it's getting distributed to create a reaction. So the drug is not something that's, adding something to your body. It's actually creating a reaction with something that's already in your body. So mechanism of drug action includes the efficacy as well, the capacity to cause an effect after it binds, the potency of the drug needed to produce the effect. For example, morphine is more potent than Tylenol. So the higher the potency, the stronger the effect on your body, right? The biological variation, the age of the person, any chronic diseases, then average medication, the medications are created with an average age of, say, a 50-year-old male with, average age, right? So if the person is an older person or if the person is a younger person, they're going to distribute the drug will take a different effect on their body. If they have chronic conditions or add something else to it, then it becomes, the therapeutic effect will be different. Psychological factors, you have stress, you have the emotional state, you have tolerance of the drug. So if I'm always taking Tylenol for something, I'm going to need more and more of that Tylenol for it to work. Right? And then drug-to-drug interaction. So if I'm taking, for example, Ambien for sleep, and then I take wine, and then it's actually going to make the effect stronger on my body because wine is also a sedative. So let's talk about the receptor sites real quick. We have the agonists, you have the antagonists, and then you have the agonists and antagonists, right? So that when the drug binds to an agonist receptor sites, it binds and it creates a reaction, right? An antagonist, the drug will bind to it, but there's no reaction created from it. And then you have the agonist and antagonist where the drugs will connect, but the reaction isn't very strong or creates a longer duration. It's less activation, basically. It takes longer to create a reaction, or it creates a very small reaction. So these receptor sites are all over your body. And so when the drug is distributed, it binds to these receptor sites. And depending on whether it's an agonist, whether it's an antagonist, or agonist and antagonist, that's the kind of reaction we will get. For example, let's talk about a beta blocker. You take a beta blocker and, what does the beta blocker do? The beta blocker, reduces your heart rate, right? So if my heart rate is normally 120, it reduces it, lower because you don't want to have a heart rate that's that high all the time. Right? For example, say I go hiking or I'm running up the mountain and my heart rate is, God knows, 1,000. Just kidding. Maybe like 150, 160, right? Your heart is trying to beat faster to, give that energy to your body to get that blood circulating, right? And so now if I take so what basically happens is when I take a beta blocker, it goes and it connects to the receptor site, to an antagonist receptor site, and it blocks it, right? So when I'm running up the mountain, my body is producing epinephrine, adrenaline. That's causing my heart to beat really fast. If I take a beta blocker, what it does, it binds onto the receptor site and it stops the adrenaline from reaching those receptor sites. So basically it blocks it. It does not create a reaction. That's an antagonist. So the beta blocker will go bind to that receptor site and block it. It does nothing. All it does is it blocks it. So when I'm running up that mountain and my body is producing that adrenaline, the adrenaline cannot connect to the receptor site because it's blocked by that beta blocker. So now when I'm hiking, my heart rate, or running up that mountain, my heart rate is not going to go up to like 150. It's actually going to stay at a normal level. And so every drug works differently. Some drugs create a reaction, like an epinephrine or insulin. It creates a reaction. It binds to the receptor site and a reaction happens. An antagonist, the drug will bind to the antagonist, and then it will block it and prevent anything else from coming there and creating the reaction. And then an agonist-antagonist will bind to the receptor site and slow the reaction. So these are some definitions on pharmacodynamics. We have adverse drug reactions. We have allergic effects. Some people have allergies, right? And allergic reactions to medications. Then we have drug tolerance. We talked a little bit about that. Then we have toxic effects. This is when you have too high of a concentration in the blood, and then that causes toxicity. We want a therapeutic range, which is a balance where there's enough drug in the body without creating toxic effects. Then we have idiosyncratic effects, basically unusual responses to a drug, right? And it's not expected, it's not normal to have it, it just happens, and it's very unexpected. Then drug interactions, when a person, we have polypharmacy, right? You have people who take a lot of different medications. So it's also important to know the drug interactions, between those drugs. We have some drugs that are additive. They increase the overall effect. Synergistic. One potentiates the other. For example, the wine and the Ambien. Ambien is helps you to sleep. It's a sedative, kind of acts like a sedative. And then you take wine with it, which is also a sedative. And so now it potentiates it. Then we have antagonists. One negates the other. So if I take a stimulant and then a sedative, they're antagonists, right? Then you have interference and displacement. Please read over these definitions. These are very important. These are some more definitions and explanations of the receptor sites and the interactions we talked about. And then what are the important things that the nurse needs to know? The nurse needs to have knowledge about pharmacology, be familiar with generic and trade names. There's no way you can memorize everything. You have access to drug guides, use those as your resource, but always look at your resources. Then you have the electronic medication administration. Usually use generic names, so be familiar with the generic names. Communicating with interprofessional teams. If you're not sure about a drug, communicate and clarify. The trade names are capitalized. Generic names are always in lowercase. Develop a working knowledge of the generic and trade names of the drugs. This is for transcribing orders. Factors that affect drug action in your body, right? You have developmental considerations, your age, for example, old and young. They'll have a different reaction. Breastfeeding. Some drugs, like we mentioned, go across into the breast milk and cause adverse effects in infants. That's another factor. Then we have children and infants. They're small, so obviously the amount of drug given to them is going to be less. The weight, the body surface area. Depending on the weight, drugs react differently in everybody's body. Somebody who weighs 90 pounds as opposed to somebody who weighs 500 pounds, the drug will act differently. Biologic sex, the females and males, depending, that affects the way the drug, acts in the body as well. Then we have cultural and genetic factors as well. Religious restrictions, beliefs, cultural practices may accept the patient's acceptance of or response to adherence to certain drug therapies. Maybe in some cultures, people or religious beliefs, they don't want certain, but for example, in Jehovah's Witnesses, they don't want blood. They're against blood transfusions, right? And so culture also affects, pharmacodynamics. Then you have pathology, right? Liver disease, GI disorders, cardiovascular disease. So if the drug cannot get metabolized, or if the drug cannot get absorbed well, the blood cannot circulate in your body, or your kidney cannot excrete the drug. All of these affect the way the drugs, act in your body. Then we have the environment, sensory deprivation, overload, or sensory is high, nutritional state. That also affects how the drug acts in your body. Administration times. Is there food and, are you taking the medication with food? Are you taking it on an empty stomach? Your circadian rhythm, all of these affect how the drug acts. Then we have psychological factors, attitudes and expectations of drug therapy. In some clinical trials, some patients appear to have effects from a placebo. It's basically most of the time just saline, and they have an effect from it because it's a psychological thing. And this this slide is very important because remember in block 1 we focus on the older adult. So age-related changes in older adults, they have lower gastric motility. That means they have slow emptying their intestines. The motility is less. They have less fat in their body, less total body water, less adipose tissue, less subcutaneous tissue. The number of protein binding sites decreases in older adults as well. They have decreased liver function, decreased kidney functions, altered hemostatic responses, peripheral venous tone. So it affects the circulation of blood through their body, right? Then they have decreased central nervous system efficiency, decreased production of oral secretions. They have dry mouth. Then we have the decreased liquid content in the skin, so they have dry skin. So all of these things affect the way the drug works in their body. So last but not least, I wanted to mention the Nurse Practice Act. As a nurse, each state has their own Nurse Practice Act. Local healthcare facilities are responsible for implementing those state regulations. The Nurse Practice Act defines boundaries and responsibilities regarding medications. It is our responsibility as nurses to know the Nurse Practice Act. Our states, for example, we live in Arizona, so the Arizona Nurse Practice Act, understand the laws regarding medication errors and their responsibility in a situation at a time when a medication error occurs, right? And understanding the laws regarding management of controlled substances. So it is extremely important. Please visit, the Board of Nursing website and read the Nurse Practice Act. And that is it for your pharmacology lecture. I will see you in class.